Professor Thacker, as we know, various studies have suggested that for patients with MEN1, the road to diagnosis is a long and arduous one, typically taking about 5 years. What message do you have for our endocrinologist audience that could help to expedite diagnosis?
No, look, thank you. That's a really important question. And I think the first thing we need to acknowledge is that this is not a situation that any one of us is happy with. I think in all fairness, we always have this problem that when you're having a rare condition, what medical students and what doctors and in all our training we're always taught is, first of all, common things occur commonly. So you need to make sure that you've actually looked at those common causes, and once you've excluded them, you will, of course, look at the rarer causes. And unfortunately, we're dealing with rare diseases with multiple endocrine neoplasia syndromes and things. So there is that. So in all fairness to the GPs, particularly, I think they have a very tough task on their hands, and it can be difficult for them, to have the wide knowledge that they need to have, as well as the in-depth knowledge as well, and having to deal with the multitude of different conditions that they're dealing with. That it is difficult. That is not to have any excuses for a 5-year lag. Okay, and clearly we need to all work together to improve this. And I think perhaps we need to have a lower threshold of referral or investigation for things, but we should look at some pointers on this. So, and I think the education is not just for any one sector of the medical profession, it's for all of us, okay, including the public as well. And the thing I always emphasize is this: first of all, if there is something unusual going on. So give you an example, we know that primary hyperparathyroidism, hypercalcemia, etc., usually affects individuals when they're over their 40s and 50s, if you want to look at it that way. It's often sort of said this occurs more commonly in postmenopausal women than premenopausal women, okay? And likewise, it doesn't occur so frequently in men. So if you see a young man in his 20s with kidney stones and primary hyperparathyroidism, this is unusual. You see a young woman in her 20s with primary hyperparathyroidism, you say, this is unusual. So why? What's happening? So age is important. Anybody who has any of these disorders at a young age should strike you as being unusual, and the threshold for referral and investigation should go down. Again, if there's a change in behavior, insulinomas with hyperglycemia can give rise to a change in behavior in young children and adults as well. And if a mum or dad comes along and says, my child is not behaving, well, they're getting aggressive for no reason, this is unusual behavior. So I think we need to sort of look at that as well, and have referrals. Endocrinologists, I think you should look at these things. The tests are relatively easy to do. So I think we need, it's having that awareness that's a critical thing. And the other things that bells should start ringing on are multi-gland disease. Histology comes back, say this is atypical, for example. And the other thing I would say to my colleagues is, please don't be shy. Ask your colleagues if you're not sure. And this happens a lot. For example, I mean, in hospitals, it's much easier. You know, I'll either have a phone call from my colleagues, or I'll ask them to say, actually, you know, I've just seen this patient with something or the other. Not quite sure. What do you think is going on here? And, you know, don't be afraid to seek advice, because at the end of the day, why are you doing that? You're doing it not because you're ignorant. You actually want to try and do the right thing for your patients. And I agree with you. 5 years is too long. I think we need to shorten that. And I think the way to shorten it is by having a greater awareness amongst everyone, and to look for those warning signals. And I hope I've alluded to some of those. I'm sure I haven't covered all the warning signals that I would like to cover, but I hope those are some pointers and of some help.
Thank you. From a patient perspective, there are still some controversies surrounding diagnosis and treatment of hyperparathyroidism in MEN1. What should an endocrinologist do if faced with a person who is normocalcimic but who is experiencing symptoms of hyperparathyroidism and has positive imaging.
Okay. Can I take this in? Let's answer this in two ways. Okay. One is the patient who is known to have MEN1, okay, or is known to have a family with MEN1, because obviously the index of suspicion here has to come down. You know, so the thing. And then let's look at it with in the more sort of general sense, somebody who hasn't got MEN1, for example, because here, you know, you need to be evaluate the symptoms and everything very carefully. Okay, so usually, if somebody has MEN1, and right now, one of the things we're doing is that because we have identified the families and we know whether they have the mutation or not, we are screening children a lot earlier and young people a lot earlier. So we are definitely picking up MEN1 patients who are asymptomatic. What genetics has done, and the genetic analysis in the last decade or so, is that it's changed MEN1 from being a disorder, a terrible symptomatic disorder that resulted in what we called end organ damage, i.e. damaged the organs, and then you've got the horrendous symptoms, to one of an asymptomatic disorder where people are well. And that's what we want to do, is to have earlier detection, earlier treatment, avoid the complications. Okay, so you know, that's what we're trying to aim for. So in the MEN1 context, by and large, you're going to get an asymptomatic patient. Okay, and the right thing to do is to watch their calcium. If it's normal, don't do anything. I advise in young people with MEN1 to delay the parathyroidectomy for as long as you can. It's much easier to manage a calcium in a young woman during pregnancy and things if she's got her own parathyroids. If she's had them removed and things, it's all doable, but it's more challenging. And likewise with young men as well, who are not going to be pregnant literally, but you know, they've got other. So I think it's best to delay the surgery and further investigations until we need them. What you want to do is to make sure there isn't damage occurring to organs. So we measure renal function regularly, we measure bone mineral density regularly, or bone resorption markers. So to make sure that the bones and the kidneys are not being damaged, and of course, listen for symptoms to make sure that it is truly asymptomatic. So delay in the MEN1 patient for as long as you can. So now we come to the difficult question of what you're asking as well now, is about the normocalcemia. And I've already alluded to that. If a patient has MEN1, is normocalcimic, let it be. Okay, you know, don't do anything else at the moment. So if a patient is normocalcimic, but they're experiencing symptoms of hyperparathyroidism, the symptoms can be quite vague. Sometimes they can be feeling fatigued, having aches and pains, constipation. Sometimes there are quite a number of symptoms that are not just due to hyperparathyroidism, and often these are due actually to the hypercalcemia anyway. So I think the first question to ask here is, what exactly are the symptoms, and are they really attributable to hyperparathyroidism? Okay. Now, recently we've got a condition that's really being talked about a lot, which is called normocalcimic primary hyperparathyroidism. And this is where individuals have a normal calcium, but have a high PTH. And the question is why? Well, what we need to do here, and these patients can be symptomatic or asymptomatic, because they're often identified through osteoporosis clinics, because that's how it's all come about. So we need to ask the question here, is this a real common disease, or is this a very unusual occurrence? And there's a very good study done by my colleague Richard Easton in Sheffield, who's looked at over 6,000 patients from the osteoporosis clinic. There are very clear defined criteria, because the PTH can be raised for a number of reasons, nothing to do with the parathyroid tumor. Vitamin D deficiency, renal failure, lots of drugs, bisphosphonates, classic drug that will put up the PTH because of a number of reasons. And bisphosphonates are given right now to women for treatment of osteoporosis. So there are many, many reasons why the PTH may be raised and the calcium is normal. And I think we need to look at all of these reasons. So in this study, they looked at all of this and looked at the criteria that are defined for normocalcimic primary hyperthyroidism, which includes vitamin D deficiency and things. And they found that out of over 6,000 patients, about 11 possibly made the criteria. But again, they looked at those very carefully, and that diminished, and ultimately they came to the conclusion that, in fact, if you look at the criteria very strictly, which was persistent normocalcemia over the period of time that we're looking at, it was 0. So what this says is that normocalcimic hyperparathyroidism is either a very rare problem or it is non-existent. Okay. Now, I want to say it's likely to be very rare, because one of the things we know as doctors, and we've known this for years, is that hypoparathyroidism, primary hyperparathyroidism, doesn't arise overnight. It's not that one evening that person went to bed and at the striking of midnight, suddenly they become hypercalcemic. You know, it doesn't work like Cinderella in that way, you know. And what we do know is a phenomenon called variable hypercalcemia, where the calcium dips up and down in the period before it completely stabilizes as being high. And I think we need to be aware of these things. So again, here, what I think we need to do is to look and see exactly where the calcium is, to see whether or not there are effects on the kidneys, the bones, blood pressure, for example, and all the things that high calcium can lead to, or primary hyperthyroid can lead to. Make sure that they're not there. And you know, if they are there, then of course it enables us to move in for treatment. But at the moment, my concern about normocalcimic primary hyperparathyroidism is, if you say this is due to a parathyroid tumor and you need to have very good evidence for that, and I think, well, let's come to the positive imaging in a minute. But if you say this and you're going to operate on this person, how are you going to monitor that what you've done has been effective? Because if the calcium was raised and the calcium came back to normal, we would know that the operation's been a success. So here, how are you going to do this? Are you going to measure it? Because you can't measure the calcium because it's normal, if you look at it that way. If you say, well, actually, the way we'll measure it is if the PTH comes down. Well, what happens if there's vitamin D deficiency? What happens if there's renal impairment? You know, it won't come down in a hurry. So I think, okay, if there are symptoms, the symptoms improve, then fine. But what happens if they don't improve? And the other problem I would be very careful in MEN1 is this, that if, for example, it is said that the correct operation when you do surgery for MEN1 is to do, because there's multi-gland involvement. A lot of people take out 3.5 glands now, the total. There is a danger, substantial danger, of hypoparathyroidism. And hypoparathyroidism has its own problems in terms of symptoms, which we can try and control with calcium and vitamin D, but often not, you know, it's not always successful. And patients do experience hypocalcemia and they do experience being unwell. And with hypoparathyroidism, there is also, which we don't understand altogether, but there's increased risks reported of renal insufficiency, cardiovascular disease, and malignancy. I don't understand how that, but those are the associations reported. So really, that's a step. You know, we also want to be very careful about taking too swiftly. So it's not an easy question to answer. And I think I would go back and sort of say, well, actually, what exactly are the symptoms? Are they definitely due to hyperparathyroidism? Is there anything we could possibly do about the calcium? Why is there normocalcemia here right now? Is it because there's vitamin D deficiency? All the things I've said before. Positive imaging, the thing about positive imaging is this: it's not a diagnosis. The way we do, the way rate diagnosis, one patient is hypercalcemic, you then measure the PTH. If the PTH is high or normal, it tells you it's likely to be primary hyperparathyroidism. Then the surgeon really needs to know, where do I go? Can I get a better localization? So we do the imaging, ultrasound and cystic BB scan, and that tells you it's a localization test, not infallible, but it's a localization test. So it tells you this is where the adenoma is likely to be. In MEN1, where there's multi-gland disease, often you will not get a localization. And also in what is said to be 10 to 15% of parathyroid hyperplasia, you will not get a localization either. And you can get false positives as well. So I think, you know, it's difficult. I would be hesitant on recommending just on the grounds of a positive image, because, you know, you can be caught out by false positives and false negatives as well. So it's a challenging thing. And I think I would really sit down carefully and exactly see what the symptoms were and see if there were any other causes that we could treat more easily and take it from there. And the other one I would do, which unfortunately is not available right now, is to also look at the other plasma biochemistry, such as phosphate, bicarbonate, and chloride, which is not measured very regularly. But in the old days, we used to measure it, and that was elevated in hyperparathyroidism. So, you know, you can look at other pointers as well. So I hope that answers, to some extent, your difficult question.
Thank you. We've just touched on multi-gland disease, so that given that in MEN1 patients are most likely to have that, what are the current problems and solutions surrounding removing the last gland? Right.
The first thing is, because you've got multi-gland disease, not all patients have multi-gland disease, and some surgeons will still quite reasonably, you can understand where they're coming from, say, I can identify an adenoma here, I'm going to take this one out, and the person's young, and I'm going to leave the rest of the glands there. What we found recently in a study of 80 children, and this is in Preston surgery, is that if you do anything less than what we call a subtotal parathyroidectomy, the chances of recurrence are high. So what most surgeons, this is a study we've had for 5 centers, including Oxford, Cambridge, the Great Ormond Street, and the Mayo Clinic and Vienna, that probably the right operation is to do a 3.5 gland parathyroidectomy, and that's another reason for leaving it till as late as possible. Okay, so you've done that, fine, and then, as you rightly see, you've got the last gland. Okay, now the question here is, have you really got the last gland? Okay, because that's the last gland you think you identified, and you've left a clip around it, and usually when the surgeon will have done this, they would have probably taken out the thymus, which has embedded parathyroid in it sometimes as well. But you may not have got the last gland there. So that's one thing to remember, that it might not be. And if where you've got the clip and it's got enlarged and it's overactive, you could take that out and you could still be okay, because there might be another parathyroid somewhere else that you don't know about. So I think that's important to consider. But still the thing, if you do really take out the last gland, you are then making that person hypoparathyroid. And then they're going to need lifelong treatment with an active form of vitamin D, such as 1-alpha-calcidiol or calcitriol, which tablet regularly, and probably calcium supplements, all calcium supplements, which is they give them a lot in America. We don't give them so much here, but you know, you're going to need lifelong medication. So I think I'm not minimizing it, but I'm saying it's not difficult to manage. Having said that, there are still dangers from a low calcium, and you know, usually most patients will experience a period or 2 or more of low calciums. And you might say, well, why is that if you've got on medication and things like that? Well, the thing is that all of us, when you take tablets, they have to be absorbed. And let's face it, that absorption could be altered by diet, these are fat-soluble vitamins and things, or tablets, so they could be altered by that. And we all know, for example, that if you happen to travel or just get a diarrhea because of food poisoning or for anything, then that diarrhea will mean that you're not absorbing those tablets, and that will precipitate hypocalcemia and need to be careful about, or vomiting for that matter. And these things do happen, and we need to be well aware of them. So most patients will experiencing some degree of hypocalcemia despite adequate treatment, and particularly the young patients, because their bones might be growing, particularly children. During pregnancy, demands change for calcium. So that's the reason why I like to delay the parathyroidectomy for as long as possible. But even in people who are past that and much older, you can still get problems there. The other problems, apart from the hypocalcemia, are feeling unwell. A lot of patients with hypopara can find that they don't still feel right, even though the calcium is normal. They feel fuzzy, foggy, just things aren't quite right, and it's an entity, and I think we need to be aware of it. And when they go on to parathyroid hormone injections, because that is available now, it's costly and it's difficult to have for a number of reasons, cost being one of them, they do feel better. The other difficulties with parathyroid hormone injections are they're injections every day. It's challenging. You can have them as infusions with a pump, but then you've got to look after the pump as well, and it's not as easy as taking tablets. So I think there are lots of dangers there, and I think we don't necessarily want to remove the last gland unless we absolutely have to.
Okay, thank you. Moving on to PNETs. Non-functioning PNETs are the most common to occur in MEN1. So in addition to late diagnosis in people not already diagnosed with MEN1, the other question is, what are the issues surrounding when non-functioning PNETs should be removed?
I think at the moment, what most people say is that if the non-functioning PNET is greater than 2 centimeters, it should come out. It should be taken out. Or if it's less than that, but it's growing rapidly, that's why often scans are done every 3 months or so, then it should come out. There is controversy about this. Some surgeons, some centers say, and they're absolutely expert at these things, that they prefer to take them out at 1 centimeter. A lot of the other centers say 2 centimeters. And the reason for the 2 centimeters is that in surgery, what often happens is that when something is larger, it is obviously larger because it's more proliferative, and these are the ones that might have actually spread to the lymph nodes or further. So that's empirically the cutoff point that there is. I think there's a lot of debate as to whether that is correct or not. The other thing is that when in MEN1, it is very, very difficult, because if you're observing something that is, say, 1.5 centimeters or 2 centimeters, we have sometimes seen spread elsewhere, and you don't know whether that spread has arisen from the tumor you're looking at or another one, because there are multiple tumors often in patients with MEN1. So it is controversial. Yeah, at the moment, I think most centers will operate when it's 2 centimeters. Some centers will operate when it's 1, or if it's over 1 centimeter in size, and it's what we call, it's growing fast, a measure called doubling time. Okay, so that's the thing here. I think what we really need are what we call in the profession biomarkers. In other words, something we can measure in the blood or the urine or somewhere that is a marker for the proliferation of that tumor. And there are some advances here coming through that really need to be validated more robustly, and see if they work in MEN1 patients. And if they can, then that will be a major advance. So there's lots of research going on there. And these are things like transcriptome assays, the circulating tumor cells is another one. There are other metabolomics approaches, as they're called, to try and identify these things, and circulating tumor DNA as well. A lot of these are still research tools because they need validation.
Thank you. So many of the patients we speak to and support are confused as to why it's difficult to predict how their MEN1 will affect them, or what a negative gene test and clinical diagnosis mean for them.
Well, thanks, Jill. So the first thing is, what you ask about is the genotype lack, or we say lack of genotype-phenotype correlation, because you can't predict it. And this is a feature of the MEN1 gene, in contrast to what happens in MEN2, where there is a genotype-phenotype correlation and you can predict a lot of things that are happening. We don't fully understand why there is this lack of genotype-phenotype correlation, and we're working on that. Like, there are many theories on that, but I don't think we have time for those right now. But suffice it to say that there are, in MEN1, if there was a genotype-phenotype correlation, then if you looked at identical twins who've got the same mutation, they should have the same phenotype. And we've published a study on twins and correlated the data on about just under a dozen identical twins. And we found that you could, those twins got different phenotypes. These are identical twins. So in MEN1, unfortunately, there isn't a convincing genotype-phenotype correlation. Okay. And as I say, there are many reasons why this could be. None of them is for certain. Now, some papers have published that if you have mutations in particular regions, they might be associated with possible aggressive pancreatic tumors or not. Okay. And those are interesting studies. The thing is that they need to be validated in much larger cohorts, because all of this is done on an association. What that means is that you could have observed that finding by chance 1 in 20 times. So obviously you need a much higher significance to have confidence. And an association doesn't necessarily mean a causality. Okay. So right now, there are some of these reports coming through, but we don't really know the mechanism. That's what we need to do. And the other challenge we have in the MEN1 gene right now is that with the new guidelines from the American and the Genetics Society's guidelines, say that there are certain criteria you need to say that this mutation is of significance. So there are quite a lot now that are being reported as variants of uncertain significance, which is very difficult for the patient, and it's very difficult for the doctor, because we've done this test and now we're telling you this is of uncertain significance, and that's no good to any one of us. Okay, yeah. So I think what many of us are planning on doing, we are doing this now, is trying to undertake some other tests of seeing how the function of that gene is altered, to then say, well, actually, this is a polymorphism, i.e. it's benign, or this is altering something here, so this is of significance and we need to worry about it. So I hope that helps to answer those questions.
Thank you.